Thank you. It's a pleasure to be here and to talk a little bit about the issue of quality of life. So I am a clinical psychologist at Weill Cornell Medicine. In part, I do research with our lymphoma program there. And I just want to talk a little bit about what we know about quality of life and psychosocial issues in lymphoma patients and some factors to consider around being aware of the quality of life issues. So I'm going to start with some basic background information focusing on what we know about quality of life and distress, which are the two constructs most widely studied in the area of psychosocial oncology and lymphoma, and then talk about some factors to consider when thinking about quality of life in lymphoma patients. So I'd like to start with this quote, which came out of the IOM report, Cancer Care for the Whole Patient. And this was a quote that I think nicely illustrates the integration of supportive care or psychosocial care in the care of cancer patients. And Dr. Adler, who was the chair of that committee, wrote, "Good quality health care must attend to patients' psychosocial problems and provide services to enable them to better manage their illnesses and underlying health. To ignore these factors while pouring billions of dollars into new technologies is like spending all one's money on the latest model car and then not having the money left to buy the gas needed to make it run." And I just like that image in the sense of talking about the integration of these kinds of care. So let me give you a little bit of background information. In terms of health-related quality of life, this is a construct that has been assessed more and more recently, I think particularly in the context of the focus on patient-reported outcomes. So it's important to understand exactly what the definition of health-related quality of life is. So you can see one definition here, the extent to which one's usual or expected physical, emotional, and social well-being are affected by a medical condition or its treatment. So in a lot of ways, this is sort of an intuitive definition, but I think a couple of things to note are, of course, this focuses on the patient's more subjective experience, which is different than a lot of the other variables that are often measured. The other thing is that health-related quality of life in particular is a multi-component construct, and you can see that reflected in the definition here. It's also reflected in many of the common measures of health-related quality of life. So the important thing about that is when looking at this literature or thinking about health-related quality of life, it's important to know, are we talking about physically related health-related quality of life, emotional, social, even existential quality of life, because the way in which we understand that data depends on how that, what is being measured, what component of health-related quality of life. So what we know, this is a sort of brief overview of the available literature, is that as you might expect, lymphoma patients do report worse health-related quality of life than the general population. Not a particular surprise. Health-related quality of life for patients tends to be worst in the first 6 to 12 months post-diagnosis. Again, probably not particularly surprising given everything that's happening and the initiation of treatment. But this is a high-risk period for patients in terms of their quality of life. That being said, there's also data suggesting that declines in health-related quality of life persist over time for a portion of patients. There's not an extensive literature in longitudinal studies, but for example, in one study, 42% reported poor or worsening quality of life up to 15 years post-diagnosis. Now, understanding why this is happening is still an unanswered question, but there may be long-term implications for quality of life in a portion of lymphoma patients. Let me talk a little bit about distress as well as another psychosocial construct that's been more extensively studied. Distress in the psychosocial oncology literature is typically conceptualized or measured as depression and anxiety. And what we see is that there are a notable portion of patients who have what we would consider clinically significant anxiety and depression. So this means that they've scored above cutoffs for validated measures that are typically validated against DSM diagnostic criteria for anxiety and depression. So again, not all of our patients are above those cutoffs, but you can see up to 25% for anxiety and 16% for depression. And again, perhaps not surprising, but important to note that there are higher rates of anxiety and depression relative to the general population. I wanted to highlight some particular data that came out of a longitudinal study of Hodgkin's lymphoma and DLBCL patients, where at baseline, which was a 3.5 to 4.5 years post-diagnosis, you can see the numbers there, up to a quarter were experiencing significant anxiety, 18 to 19% were experiencing significant depression. These patients were followed for 4 years and assessed annually. And I think what's notable is a quarter of the sample reported being distressed at either some or all of those time points. So again, just an indication that at least for a proportion of our patients, the psychosocial impact of their disease does persist quite far over time. The other thing in terms of depression and anxiety is certainly patients who are experiencing these symptoms, they are unpleasant symptoms to experience in and of themselves. In addition, patients who report high levels of depression and anxiety also report other problematic outcomes like worse global health status, lower emotional and cognitive function, and even worse fatigue and insomnia. It's not clear the causal relationship between these things, and of course they probably are bidirectional, but it does suggest that distress may complicate the picture for a lot of these patients and impact them in other ways. So again, a very brief overview of the literature in quality of life and distress in lymphoma patients. I want to switch to talk a little bit about some factors to consider when thinking about quality of life in these patients. So first, across studies, there are some demographic variables that tend to be associated with higher levels of distress. Younger age, female gender, lower education levels, and a greater number of comorbidities. Obviously, for many of these, they are not modifiable, so we can think about them as risk factors potentially, that the patients with these demographic characteristics may be at increased risk for high levels of distress. In some similar ways, there is some data, although it's limited and much more work needs to be done in this area, about the relationship between the treatments that lymphoma patients are receiving and health-related quality of life. Not surprising, treatments that tend to have higher toxicities are associated with worse health-related quality of life. There has been some research comparing different types of treatments on health-related quality of life, and I'll note too, again, the literature is not extensive, and part of the issue is that different studies compare different treatments, so firm conclusions really can't be made. But in a study published in Lancet Oncology in 2014, by author Ardeshna, rituximab induction plus maintenance was compared to monitoring or watch and wait. And what they found on the psychosocial side was that perceived control, which is typically conceptualized as a psychologically healthy state, was higher in the rituximab condition, whereas worry was higher in patients who were under monitoring. And then avoidance, which the data shows is a maladaptive coping strategy, increased in patients who were in the monitoring or watch and wait condition with no change in rituximab. So again, potentially not conclusive. There were some limitations to the study, but these results may suggest that patients might feel more distressed in the context of care where they feel like they're, quote unquote, not doing anything. And even if treatment is not indicated, that patients' experience of that may be very distressful. Another study that I'll highlight in this similar vein, although again comparing different treatments, was the RESORT trial results published in JCO in 2015 that compared maintenance rituximab versus rituximab retreatment. And here there were no differences in the treatments in terms of quality of life and anxiety. And in fact, for the whole sample, anxiety decreased over time. So again, more research is needed to really examine the differential effects of various types of treatments on distress and quality of life. But one concern, and coming out particularly out of the Ardeshna study, is that distress may influence patients' treatment decisions. So in this comic, which is sort of a lighthearted take on this issue, the physician is saying to the patient, there's really nothing wrong with you, but I feel a little surgery might make us both feel better. Now, certainly I'm not suggesting that anybody is making treatment decisions based on helping themselves feel better, but one concern is that patients' distress might influence their treatment decision making. And there is some data on this in prostate cancer patients that shows that patients' anxiety was the most robust predictor, in fact, of early initiation of treatment. So it just gives us pause in terms of thinking about how the patient's experience might influence their treatment decisions. So, one way to sort of think about this is in terms of patients' understanding of their illness and treatment. And it can be sort of amazing how patients can misunderstand their illness. So what you see here is how the patient on the left and the physician on the right are defining chronic. So the patient is seeing himself dead and buried, and the physician is saying this is something we need to keep our eye on. And so it's just very easy sometimes for patients to misunderstand the information they're being provided. We actually had this happen in one of our clinics not too long ago, where the patient's oncologist told them that their disease had progressed. So they had bad scan results. The patient came out feeling very good about that appointment because they heard that their disease had made progress. Progress versus progress. A very easy way. The oncologist was clear and upfront about what the scan results were, and the patient just misunderstood. So very easy for this to happen. But having patients understand their illness and treatment understanding may be one way to help them manage distress and make treatment decisions. So I'm sure that many of you have your own words around these kinds of issues. There are some examples here. It's always very interesting, even as a psychologist, to ask patients what their understanding of their illness is and hear them put it in their own words. So one sort of simple way to understand what the patient has heard. And then normalizing emotional responses. So again, you probably have some of your own language around this, but remembering that patients don't really know what to expect. So even a statement like, sometimes the thought of watching the cancer makes people nervous, or like they're not doing something. Do you feel that way? And just an easy way to sort of check in terms of how the patients are reacting sort of psychosocially or emotionally to what they're hearing. These kinds of issues can be particularly complicated and perhaps important in the context of end-of-life care. So there has been recent data showing that patients with heme malignancies receive higher rates of aggressive care at the end of life. And it's unclear exactly why this might be the case. It likely has to do with a lot of the nuances of many of these diseases. But they are more likely to get aggressive end-of-life care and less likely to receive palliative and hospice services. And out of the solid tumor literature, what we know is that a lot of patients who receive aggressive care at the end of life don't have survival benefit, but do have decrements in health-related quality of life. That level of data is not yet available in lymphoma, so we want to be careful about making a jump there, but that's why this issue might be something we want to think about more. In the area of solid tumors, we know that rates of misunderstanding in the context of terminal disease are quite high, and that when patients do accurately understand that their disease is terminal, they are less likely to prefer and receive aggressive end-of-life care and more likely to engage in advanced care planning. So there are a couple of groups focusing on heme malignancies and end-of-life care in this realm, and it'll be interesting to see what happens, but certainly some issues to think about in terms of patients' quality of life and treatment decision making. Of course, these are conversations that are very difficult to have. Many of you have probably heard of the SPIKES model or acronym for how to have conversations around when chemotherapy or treatments are not working anymore. There's a lot of research and literature on this, but finding a private setting, checking patient understanding, asking the patient what they want to know, not necessarily because that's all we're going to tell them, but just so that we understand sort of what they're comfortable with, providing information about the clinical situation, allowing some time for the patient to express their emotion, and then summarizing and strategizing. There is much more information and details about using the SPIKES model. There's also a nurse's acronym around empathy and so forth. But just to sort of highlight that there are guidelines for having these kinds of conversations and thinking about them. The other thing is sort of thinking about in terms of quality of life, what the patient's values are when we are in the context of end-of-life care. These are some very basic prompts, but the idea being, one of the main barriers, and this was identified in heme malignancy providers, one of the barriers is concern about reducing patients' hope, which is certainly an important thing to think about. And so the way that this is thought of is rethinking in the context of a terminal disease, hope for what? And again, a very hard transition to make, but when the hope is no longer for cure, can the patients have hope for living a life that is consistent with their values, that has meaning to them, and can we think about providing them the care they need to reach those goals? So stepping back from illness and patient understanding and thinking again about this issue of sort of health-related quality of life and distress, asking patients, just patient self-report, asking patients about how they are feeling and coping is in and of itself an intervention. So there is data suggesting that even if we just ask, that patients report lower levels of distress, a better relationship with their oncologist, and also higher levels of satisfaction and confidence in their care. So really just asking patients how they're doing can help them. There's also some data that suggests it improves clinical trial enrollment and reduces the likelihood of malpractice. I don't know if we want to go there, but there is some data showing that as well. But in the context of busy clinics with not a lot of time, it's really easy for something like this to happen. So here the patient is saying, you're not listening to what you're hearing, right? The number of pressures and requirements on oncologists is so great that integrating any more questions is really challenging. And so it's very easy for something like this to happen. And there are real barriers to integrating a lot of these questions. Time, of course, uncertainty about how to ask. And then also, and this is sort of a widespread problem, is providers feeling like, well, if I ask, I really don't have resources for referral. So what am I, if I ask and then I have nothing to offer, that doesn't feel right. And these are all certainly very valid points. So let's see if we can just think about each one briefly. So time is certainly a concern, but there is data suggesting that even very brief episodes of empathic communication can be beneficial for patients, associated with less anxiety and more positive provider ratings. That was 40 seconds. So even a very brief question, a very brief intervention can be effective. And then in another study, they tested the impact of an oncologist saying 3 reassuring statements. They were statements around how the oncologist was going to stick by the patient, how they were going to work on this together. Those patients who heard the 3 reassuring statements had less uncertainty and anxiety, greater self-efficacy, and greater satisfaction with care. So while time is always an issue, it is important to remember that even a very brief assessment can be effective. So another barrier is often knowing what words to use or how to ask. And again, you probably have language that you have found works for you. Here are some additional words to consider. Oftentimes it can be helpful to normalize patients' distress. We see cancer patient after cancer patient after cancer patient. Many of our patients have only had cancer one time. They don't really know what to expect. And this can materialize in both ways. Patients can worry that they're not coping well or that they're going crazy. And And so normalizing for them that their distress is in reaction to what is a very stressful situation can really make patients feel better. Other times patients don't even know, if you ask them sort of how they're feeling, they don't even know what to say. So providing some examples, some people feel very worried and can't get these anxious thoughts out of their heads. Is that something that you're experiencing? Can give patients some language for understanding or putting words to what they might be feeling if that's something that's difficult for them. The other reaction sometimes that patients will have is, well, of course I'm nervous. I have cancer. Of course I'm anxious. And that's certainly a reasonable thing to consider. And like we saw in the rates of anxiety and depression and quality of life, many patients cope quite well with their cancer diagnosis. They do okay. They certainly might be nervous and stressed, but they are able to manage their situation, maybe have a good support network and so forth. So one way to try to identify patients who might be struggling a bit more or a bit problematically is to assess the degree of impairment that their anxiety or depression is having. And again, here are some sample words to consider. This is not, of course, an exhaustive list, but to try to figure out, are people becoming so depressed that they can't get out of bed, that they can't complete ADLs or IADLs? Is it interfering with their relationship function and so forth? To identify patients whose distress might be causing some impairment. So if we go from the last cartoon to this one, this patient is saying, "You very good listener, you hear my feelings," which is a hard thing to do, but something that can be very beneficial for patients. So finally, let's address the issue of limited referral options. Recent data that assessed cancer centers across the United States found that this is a ubiquitous problem. Of 57 U.S. cancer centers that were in a particular study, only about 20% reported high capacity to provide quality psychosocial care. 20%. So the issue of limited resources is certainly a big one. And then you can see there, 36 to 50% of cancer patients with elevated distress receive psychosocial care. So this is of patients who are reporting problematic levels of distress. This is the percent who receive psychosocial care. So we are really in a system where these referral options are quite limited, which poses challenges, of course. And patients feel it too. So this is out of a study that was assessing unmet needs in hematological cancer survivors. And what you can see on the far right is that a notable proportion of patients were reporting unmet needs in the domain of emotional health. So emotional health and relationships were toward the top, with 10 to 17% of survivors reporting unmet needs. So patients feel this as well. So of course, if you're in an institution where there are mental health providers, that's an easy start. For many of us where those resources might be limited, I just wanted to make you aware this is certainly not, this is not going to help with all of the problems around limited options, but there are many organizations that provide things like helplines and support groups, peer mentoring for patients, and they often match by disease. And so I listed some there just so that you are aware, and these are resources that you might be able to provide to patients. So for example, the American Psychosocial Oncology Society has a helpline that patients can call. It will also help them find psychosocial resources within their area and so forth. So just some additional ideas if you do have a hard time finding psychosocial oncology providers for meeting the needs of your patients. So finally, take-home messages. Obviously, multiple factors are related to patients' quality of life. We do need much more research in this area to really pin down the particular differences, but that even assessing patients' quality of life and distress can have a positive impact, and so might be worth considering. Thank you.